Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
It's a common problem that affects at least 50% of postmenopausal women, yet only about 7% are receiving treatment. We're referring to a condition called Genitourinary Syndrome of Menopause, or GSM. It's a term that used to be called atrophic vaginitis. Atrophic referring to atrophy or shrinkage of the vagina. Vaginitis, I don't exactly know why they added the itis, which usually means inflammation, but probably just as well that we got rid of that term. Symptoms of GSM can include vaginal dryness, itching, painful intercourse, and genitourinary syndrome increases the risk of urinary tract infections, all the result of low levels of estrogen that go along with menopause.
The good news is there are treatments that can help if you're willing to talk to your provider about it.
That's critical.
Yeah, here to discuss is the director of the Mayo Clinic Office of Women's Health, Dr. Stephanie Faubion. Welcome back to the program, Dr. Faubion.
Thanks so much. Delighted to be here.
Dr. Faubion, nice to have you on the program again. So I think that the name change is interesting, from atrophic vaginitis to genitourinary syndrome of menopause. I guess the name change was good, but why? What prompted your society and women's health experts to do that?
Well, there were a number of factors that played into that, and one important one was that women didn't associate the condition with menopause. And so it was sort of unclear why these symptoms were happening, and therefore women weren't going to their doctors saying, you know, this is happening to me, can we do something about it? So it wasn't really associated with menopause, was one. The second was the term atrophic vaginitis doesn't have anything to do with the urinary tract. So societies were trying to pull in the urinary symptoms like the urinary frequency, going to the bathroom more often, the urgency, and the urge leak, which are all symptoms of the same thing, low estrogen. And so tying in that for both providers and for women was helpful. And the third was, as you mentioned, atrophy means shrinkage, and no one wants to think of their genitals as shrinking. So much like the term impotence went to erectile dysfunction, we're now taking away that more pejorative term and making it something that women and providers can understand and that's more acceptable.
And just saying GSM, somebody might be less afraid to say to their doctor, I think I have GSM.
Yeah, it's a little more hip than atrophic vaginitis.
What age are women when they usually experience their first GSM type of experience?
Well, this is typically menopausal women. So most of the time women are around the average age of 51 when they go through menopause. And typically it doesn't start immediately after that last menstrual cycle. It sometimes takes 1 to 2 years for those symptoms to develop. So whereas hot flashes and night sweats tend to start even in the years before the last menstrual cycle, these symptoms tend to come on a year or two after the last menstrual period.
I think one of the important things that you emphasized or pointed out in your article is that this condition is under-recognized.
Oh, for the large majority of women, and think about that. So over half the women that are postmenopausal have these symptoms, but a lot of times they don't bring it up. They think it's just a natural part of aging. They accept it somehow, and they don't talk about it with their providers. So
that's you, isn't it?
I forgot to tell you,
Yeah.
turn your pager off.
They don't talk about it with their providers. Oh, crap balls.
What was it for?
It was at 3:30.
Okay,
Crap balls.
sorry.
Oh, and now I just remember they don't talk about it with their providers. Is that what you were saying?
Yeah, we
Okay.
could just start back there. I could ask the
Okay.
question again.
Ask the
What was
question
the
again.
I think one of the important things that your article pointed out or emphasized was that this is an underdiagnosed condition.
It is incredibly underdiagnosed. So as we were talking about, there are some 50 to 60% of postmenopausal women who are affected by this condition, yet only about 7% actually receive treatment. So think about how many women are actually experiencing these symptoms, but the majority of time they don't bring it up with their providers. They don't associate it with a menopausal transition. They think it's a natural part of aging. They don't think anything can be done about it. And frankly, they're embarrassed to bring it up with their providers. But on the provider side, providers aren't really educated about these things, and a lot of times they are embarrassed to bring up these topics with women, and so there's sort of a disconnect in the middle there where women aren't getting treated.
Which is the bigger problem, that women are afraid to ask or doctors are afraid to bring it up?
I think they're equal. Actually, studies have shown that women would prefer that their provider bring it up. But providers are uncomfortable and they feel like they don't know what to do with the topic and they're embarrassed to talk about sex. And so it just is kind of the elephant in the room.
Do these symptoms that you've talked about resolve over time? Do they get better over time without treatment or no?
Well, here's the tough part. So hot flashes and night sweats, even though they may last for a long time, they do typically get better with time, whereas these symptoms of GSM just get worse over time.
So that's the vaginal dryness and the urinary problems.
The vaginal dryness, the pain with sex, the urinary problems, yes. And so it's important to not just tie this with a sexual activity with pain with sex, because women can often be uncomfortable just sitting or wearing jeans or getting on a bicycle or wiping after they urinate. This can be incredibly uncomfortable. So it's not just about sex, their sex lives.
How do you make the diagnosis? Are there any tests that you need to do to confirm the diagnosis, or is this pretty much just by history and knowing the patient's age?
Well, it can be just by history and knowing the patient's age. We do encourage providers to at least do an examination because there are some other things that can be mistaken for these same symptoms. Some conditions like lichen sclerosis can be mistaken for these symptoms.
Lichen sclerosis?
Vulvar lichen sclerosis. It's a condition that's inflammatory and probably autoimmune in nature. But we don't want to.
Pretty rare, though.
It's
right?
rare, but we don't want to miss these things. Sure. So I would encourage providers and women to have an exam just to figure it out. But yes, for the most part, you can pretty much nail it on the head by saying you're a woman of a certain age and you're having these symptoms and it's most likely GSM.
Okay, so now that we've set the table
Established
here,
the diagnosis.
and I am feeling like, oh golly, how can we help? What treatment options are there for women who are dealing with GSM or just joining the journey towards menopause? What can we do?
So the good news is there are lots of things that we can do about this. And this starts with just using some over-the-counter products to begin with. And lubricant moisturizer 101 education here. So moisturizers are like face cream for the vagina, and they can be used every day, every other day on a regular basis to help lock in moisture. And just like you would get up and take a shower and put on your lotion, it's the same type of thing. So a moisturizer. The others are lubricants, and those are used as needed for sexual activity. So if those two in combination are not doing the trick, then we have prescription therapies that are available, and most of those are based around hormonal treatments. The most common and most well-known is low-dose vaginal estrogen, and it's available in creams, ring, and tablet, all that go in the vagina. Very effective, very low dose, and with very little concern about any long-term effects.
What about the urinary symptoms of people, if they're leaking? What are the different, does that help with that symptom?
It helps with the urinary frequency, urgency, and urge leak. So vaginal estrogen will not help with the stress incontinence, which is cough, sneeze, leak. That is more due to relaxation of the pelvic floor muscles and that sort of thing. So estrogen is not going to fix that, but estrogen will often take care of that urgency and urge leak.
All right, we're talking with Dr. Stephanie Faubion, who is director of the Mayo Clinic Office of Women's Health. We're talking about genitourinary syndrome of menopause, used to be known as atrophic vaginitis. Time for a short break, but when we come back, we've got a myth or matter of fact.
Ooh, and it is ripped from the headlines. Women should take hormone therapy to prevent heart disease.
You're listening to Mayo Clinic Radio on the Mayo Clinic News Network. Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCray.
We're back talking about menopause and the genitourinary syndrome of menopause with a Mayo Clinic expert, Dr. Stephanie Faubion. Myth or matter of fact, Tracy?
Well, it's ripped from the headlines. Women should, from this week's headlines, as a matter of fact, women should take hormone therapy to prevent heart disease. Is that a myth or a fact?
Oh, well, so the recent headlines would say, no, that is not true. Although I would contend that there is still plenty of data out there that would support that systemic hormone therapy does reduce heart disease risk for women, especially for those who are newly menopausal and within about 10 years of the menopause transition. So we definitely have a controversy out there.
Well, just last month, Dr. Kapoor was here and said, oh, we've changed it around.
The data do support the fact that there are good things about hormone therapy, especially for women in their 50s. And I know the United States Preventative Services Task Force really doesn't believe that, but I think we are moving back around toward that direction, even if we're not outright recommending it as a preventive strategy. Women who are taking hormone therapy for bothersome menopausal symptoms in their 50s will definitely get some added benefits, including bone protection and heart protection.
Well, but we stopped recommending, or you women's health experts stopped recommending hormone therapy for postmenopausal women because I thought it didn't have any effect on heart disease, or it increased your risk for heart disease. We knew it did something for bone health, but the other issue was it increased the risk for breast cancer.
So this is all very complicated, but it comes down to what kind of hormone therapy are we talking about? How old is the woman? And how far away from the menopause transition is she? So when the Women's Health Initiative study came out in 2002 and said hormone therapy is bad, they were lumping all women together and all hormone therapy types and regimens together. And so when you averaged it out, the average woman in the Women's Health Initiative was 63. And that's not the woman we put on hormone therapy. That's not the woman who comes to our office complaining of hot flashes and night sweats. And when they ultimately teased out that data between the women who were 50s and the women who were 60s and the women who were in their 70s, the story becomes much more clear. So for starting women on hormone therapy for the first time in their 70s, there's more heart attacks and strokes. This is not surprising. These women already have some heart disease or vascular disease that's beginning, and putting hormone therapy on top of that might increase their risk. For women in their 60s, the risk was more neutral, and for women in their 50s, there was actually some benefit. So additional studies since that time have confirmed that, and in fact, observational studies before that time also support that. So we have plenty of data to suggest that heart disease risk is lowered in women who are on hormone therapy in their 50s.
If you start a woman, postmenopausal woman, on hormone replacement therapy, do you try to use the lowest dose possible, and then is it forever, or at some point in time do you stop it?
Well, that's a great question. So we have moved beyond the lowest dose for the shortest amount of time. And the reason for that was that providers were constantly trying to take women off and underdose them. And so now we just say it's the appropriate dose, the appropriate route of administration for that particular woman. And we're not timing it on any number of years or age. We are timing it based on the woman's needs. So this is an individualized discussion with every woman based on her medical history, based on her family history, based on her symptoms, and based on personal preferences.
Has it always been true that hormone replacement therapy, and everybody has agreed that one thing hormone replacement therapy does is improve bone health and help prevent osteoporosis?
I think there's no question about the bone benefits for hormone therapy. I think the bigger controversial issue is the breast cancer risk. And that differs between whether or not a woman is on estrogen plus a progestogen, so that means a woman with a uterus, or whether a woman is on estrogen alone, she's had a hysterectomy. And the breast cancer risk is not increased in women on estrogen alone. In fact, the trend, and especially the longer follow-up, shows a decreased risk of breast cancer in those women. But the risk of breast cancer may be increased in women who are on a progestogen after about 3 to 5 years of use. And in general, it's a very small risk. It's an average of about 8 to 9 extra cases per 10,000 women per year after 5 years of use.
Pretty minimal.
It's pretty minimal.
Anything else you want to ask about the hormone replacement therapy before we go back to GSM?
Nope, I'm just patiently waiting.
For your prescription?
Well, I try to look on the bright side of these things, and because I am getting to that special time of life, it's probably fair to say there's never been a better time to be a woman going into menopause than right now, because there's places like the Women's Health Clinic medicine seems to be recognizing that this is something important that affects women's quality of life.
It affects women in so many ways, and it's not just about the hot flashes and the night sweats anymore. And even a bigger picture, we're coming to understand that hot flashes and night sweats are not always benign, and they may actually portend cardiovascular risk. So we are understanding that estrogen affects every cell and every tissue in our bodies, and it's not just about the hot flashes and the night sweats.
So there's a couple of other treatments for genitourinary syndrome that I wanted to ask you about that you talk about in your article, and one was pelvic floor physical therapy. Are there some women who need that? What's involved, and how does it help?
So pelvic floor physical therapy would be something that we might use for women who have pain associated with intercourse. And so in addition to getting those vaginal tissues healthier again with vaginal estrogen, or there's some other products, a new DHEA product has recently been approved by the FDA. So in addition to getting the tissues healthier, sometimes women have very tight muscles. Because they've been used to having painful sex. And so sometimes a physical therapist to help relax those muscles is very helpful.
What about laser treatments? I saw that in your article
What?
and hadn't heard of that before. Laser on the genitals.
So there's some very interesting data that's coming out recently, and I know a lot of your audience will probably have heard of this, but much like lasers for facial uses, they've come up with a laser for
You mean like for wrinkles?
Yes.
Laser for wrinkles?
Exactly,
facial
for
wrinkles?
improving vaginal health. And what it does is it creates very tiny little wounds in the vagina, and that causes a healing process, which thickens the tissues up again. And so while there are short-term data, we have about 3-month data on this that shows that it works. What we don't have yet are the long-term studies to show us that it's safe. And so I think this is new and emerging, but the jury's still out on the long-term safety of this.
Far from a gold standard of treatment of this particular problem.
Far from it.
Because you were so kind when I sent you a message and said, do you have menopause psychiatrists in the Women's Health Clinic? You said, well, technically, I suppose that we do. I feel like I need to, in kind, say, there are also emotional issues that come along with both going through menopause and certainly dealing with GSM.
You make a great point. And women who have never had a single problem with anxiety or depression can have issues at menopause, but especially those who have maybe had some postpartum baby blues or had PMS mood issues during their lives. Those women are more likely to struggle with mood during menopause, and that is a key issue. It's treatable. Sometimes even estrogen alone will help make mood symptoms better. But as you mentioned, the psychological impact of GSM cannot be underestimated, and it impacts women's quality of life and their relationships with their partners. So again, it's important for women to speak up and say when they're having a problem.
That's the physician saying that it should not be underestimated. And I sincerely and very specifically want to say to any woman who is listening right now, if you feel like this is driving you crazy, trust me, it feels like it is, and it'll be okay. You just have to say something. I really did. It's been a hard time. It has been a very hard time.
Well, and there have been multiple surveys that have proven this over and over and over again. Vaginal dryness is a huge issue for women, for their partners, for their sex lives, for their relationships, and it's addressable. It's a treatable issue.
You know, that's all very good to know. And so, in addition, you wrote this excellent article on genitourinary syndrome of menopause, but you also wrote a whole book on menopause. Tell us about that.
Oh, it's the Mayo Clinic Menopause Solution. It was published last year, and it's still available where books are sold. But we basically wrote it as a reference for women because we couldn't find anything that was reputable out there, so we came up with one.
You know, maybe not a gift to give to your special woman for Christmas or a holiday, but something you could get for yourself. Right?
Absolutely.
Put that under the tree, huh?
Treat yourself to it. Absolutely. It's a great resource.
All right, Dr. Stephanie Faubion, Director of the Mayo Clinic Office of Women's Health, talking about genitourinary syndrome of menopause. Thanks so much for being with us.
Thanks for having me.